Hey guys, it's Chris here from Physio Inc. South Penrith and Physio Inc. Nepean. We're just going to do a quick video today. It kind of follows on from an article or a blog post that's up on our website. It went up a couple of weeks ago, and that's to do with ACL surgery and the type of grafts that surgeons will tend to use. Some surgeons have their preference, and some surgeons will be guided either way based on the exact presentation of the patient. Now, what we're going to deal with today is the Patella tendon graft, the hamstring tendon graft, and what's called a LARS graft, which is a synthetic graft, and we'll also touch on some exciting research at the end of the video today. If you have injured your ACL or ruptured your ACL and you are wondering whether surgery is what you need, there's a different blog up on our website which can talk you through that, so definitely go and find that. But if you are going down the surgical path, the graft choice can be quite important. So what we'll talk about today, like I said, is patella tendon grafts, hamstring tendon grafts, and LARS grafts. We'll start with a patella tendon graft. And now what that is a graft taken from the patella tendon, which is the tendon here at the front of the knee. It runs from the kneecap down to the tibia. And what they do is they take the middle strip of that tendon, the middle third, and actually use that to replace your ACL. Now there are some pros and cons with this. One of the big pros is that when they do take this strip of tendon, they actually leave a bit of bone on each end, and then they insert that bone into some pre-drilled holes within the knee, within the actual knee itself where they replace the ACL. Now, because they're putting bone into the bone, it heals much more quickly, which is great, and it means we can sometimes speed up our rehab. One of the cons, however, we do find that patients are much more likely to have pain at the front of their knee when they start to get into running, or even when they start to kneel on their knee. So that's something worth considering. The next thing we'll talk about is the hamstring graft. Now what that is, if we go to the back of the knee, we've got three hamstring muscles. Two of them run down the outside of the knee. Sorry, one of them runs down the outside of the knee and two of them run down the inside of the knee. Now they take this tendon graft from the inside of the knee there. Now, one of the pros with this is that you don't get as much pain at the front of the knee when you start running and when you start to kneel on it. But one of the cons is that you start to get some decreased healing time of the actual surgery. That is because unlike the patella tendon graft, they haven't taken some bone off with it. So the tendon has to heal into the bone rather than bone healing into bone. And that process can be a little bit slower, which is a consideration that we do have to make. Another con is that it can sometimes leave patients with some bruising behind the knee, which can last for a month or two after surgery. What we'll talk about now is the LARS graft. Now the LARS graft is a synthetic graft. Now, this will often be used when patients have undergone multiple ACL reconstructions. Because they've undergone multiple reconstructions, chances are they've already used their patella tendon and or their hamstring tendon, so the surgeon does need another option. Now, that is the synthetic graft, the LARS graft. As its name suggests, it's actually a synthetic material that goes into the knee to replace the ruptured ACL. Now, one of the cons of this is we just simply don't have enough long-term evidence on its efficacy. It hasn't been used widely enough or for long enough for us to make an educated call on what the long-term effects are and if it is a viable option long-term for knee stability. As I said before, we also wanted to touch on some exciting research that's come out in the ACL surgery kind of area. And what that is a study that was done a couple of years ago now, where they used what's called a blood bridge. Now what they did in this study, instead of using a graft of any kind, what they did is they got patients who had ruptured ACLs, they put them under anesthetic and the like, and then they got a sponge, soaked it with the patient's own blood, and then popped that sponge on the inside of the knee, and they actually put it between the two ends of the ACL that had been ruptured. And the hope was that the ACL would essentially grow across that sponge, hence the term blood bridge. Now, the exciting part is that there were 10 patients in the study. All 10 patients actually had the ACL reattach across that bridge. What we're still waiting on though, and what is exciting into the future, is whether it's actually a viable solution. What I mean by that is, yes, the ACL is reattached, but one, is it strong enough? And has it actually reattached in a tight enough position? If the ACL is, not strongly united, there's obviously a chance that we could re-rupture. And if it's not tight enough and it's too lax, it's not going to give our knee the stability that it needs. Nonetheless, it's an exciting kind of place and it's an exciting time to watch what happens in this area. Now, for the full articles of what we've just spoken about, head to our websites. That's www.physioincnepean.com.au or physioincsouthpenrith.com.au. Go to the blog section and it's all there for you. Till next time, guys. Cheers.